Good morning, good afternoon, good evening, wherever you're located. We welcome you to our event this morning. So it's kind of like mid-morning here. And I know some of us are located like in the West where it's like 9 a.m. We want to welcome you to Pecanut Nurses Week Celebration 2024. Yay, happy Nurses Week, everyone. Thank you for joining. Thank you for spending this afternoon with us or spending this morning with us. We're excited that you're able to join us today. And today we have three incredible speakers in our midst, and we're really, really excited about what they're going to share with us today. But before we start, I want to quickly, encourage us to situate ourselves wherever we're located. So for me, I am located somewhere in the Greater Toronto area. And where I'm located sits on the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee indigenous peoples. Today, this meeting we are having right now, where I'm currently located, is still is the meeting place for many. Is home to many indigenous peoples from across the Turtle Island, and I am personally grateful for the opportunity to work, play, and study on this land. I also want to respectfully acknowledge the legacies and contributions of my ancestors who have been all over the world, especially in Western countries, for over like 4 or 5 centuries. I am here because of the successes that they were able to accomplish through their struggles. It was not easy, but they fought for that. They fought for their freedom, and I am here today because of them. So I invite everybody, wherever you're located, to situate yourself. When we do land acknowledgement, it's not what we do because it's mandatory, but it's a call to, invite all of us to reflect on the land on which we are located and how, in some ways the land had disadvantaged some people or systemically marginalized some people, and also to think about how we can, make the land better and how we can work collectively together. So welcome, 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 and thank you for joining us. Yes, it's Nurses Week, and just before we get into, why we are here today, just a few housekeeping. Right now, all attendees in the room do not have their microphones turned on or their cameras turned on. That was on purpose, but we are going to change that as soon as the presenters are done presenting. So don't worry, we want you to engage. You can still type your Q&A. You can type it in the chat as well. We want you to ask questions as they are presenting. And at the end of their presentation, we have some time to, get your mics on, get your cameras on, so we can really see ourselves and talk, because this topic we're about to discuss today, I know it's something that, resonates with many people. It's something that many of us nurses and even non-nurses hold dearly, because it affects us all, whether we identify as someone of African descent, or we identify as a white person, or someone of Asian descent, or an indigenous person. When there is injustice that affects one group of people, it affects all of us. And today we want to shift that conversation to understanding what can be done nationally. So we are not, yes, we'll talk about maybe things that could be done like at, each unit level, organizational unit, but we really want to look at national strategies for confronting racism in nursing. Sometimes, when leadership is not top to down, when initiatives are not from top to down, it's hard to implement sometimes. And that's why I want to really unpack that, look at the history, which our first speaker is going to dig a little bit into where we're coming from, where we are right now, and what the future should look like. And then our second speaker will talk about, from that national perspective, like what's the chief nursing officer's role in all of this. And lastly, we have a third speaker from the United Kingdom, which I'm really, really excited about, to share their experience about what she does in the in the UK, and how we can learn from that as a country. So without further ado, I am going to hand over to my sister, who is co-hosting this webinar with me, Dr. Jifa Dodino. Yeah, over to you.
Thank you so much, Demiola. Good morning, good afternoon, and good evening to you, depending on where you're joining us from. I do also want to acknowledge that I am joining you today from the traditional and ceded territory of the Lekwungen people. And on this side is nice and sunny. So I'm hoping that the weather outside of your window is equally as beautiful. Thank you so much for joining us today. And as my lovely co-host and sister, Damiola, had indicated, today we're celebrating Nurses Week. And by giving highlights to the issue around racism. So one of the goals of the Pan-Canadian Nurses of African Descent is to dispel the misconceptions of the association of our darker skin pigmentation to be the predisposition for many disease development. For centuries, race has been misrepresented to be biology when disparities are identified in health research. Instead of using race as a risk marker to explore reasons for the identified disparities, researchers label race as a risk factor for the development of that disease or condition under investigation. This misconception, as you know, has fueled racist ideologies, resulting in racial discrimination. According to the international human rights laws, racial discrimination is defined as any distinction, exclusion, restriction, or preference based on race, color, descent, national or ethnic origin, which has the sole purpose or the effect of nulling or impairing the recognition, enjoyment, or exercise on equal footing of human rights and fundamental freedoms in the political, economic, social, cultural, or any field of public life. Nurses and nursing are not immune to the experiences of racial discrimination, but this topic has received little attention till now. In an ongoing CIHR grant-funded project that we are doing in collaboration with CNA, other organizations, including this one, and of course with Dr. Etua as a co-PI, we explored the experiences of nurses' experiences of racism and other forms of discrimination in the workplace. The results from the recent of this multi-phase study essentially confirmed what many nurses have been talking about for decades. Without stealing the thunder from CNA, who will be releasing that report soon, I can share a few interesting highlights that we found. One interesting thing that we found was that the experiences of racism against people of Black race predominate the literature. Another interesting thing that we saw was that in the trend of publication, the experiences of Black people or Black nurses actually propagate the publications. So what I mean by this is if you, our scoping review found literature from the 1970s till now. And in that range, you see two distinct peaks, 1990 and 2020. When you look at the historical context of those times, the events that drove the increased publication in those years were mainly events that were happening to Black nurses. So in the 1990s, there was a group of nurses from Ontario that sued their employer because of discrimination. And they not only sued, they actually won. So that increased the publication around this topic. And then in 2020, many of us were around to see that, where the social movement around the brutality of police brutality against Black people started in the US and sort of swept across the world. That again propagated the increased publication of papers and opinion pieces on anti-Black racism. So today we're focusing on anti-Black racism, not because it's the most important or because it's the only one that is around, but only to highlight that in this, if a trend that we observe in the literature is true, that is that experiences of the Black people appears to propagate publication and all not, and what have you not. The hope is that by giving light and shining continual light on this issue, that can bring us to more of an action. As Daniela has alluded, we don't want more publication and things on this topic. We actually want specific strategies to be implemented. So I thank you so much for joining us today. And on that note, I'm going to turn it over to, or introduce Dr. Etoa, who will be our first speaker. So Dr. Etoa, Josephine Etoa is a full professor and OHTN chair in Black women's HIV prevention and care at the University of Ottawa's Faculty of Health Sciences, School of Nursing. She is the past president of the Health Association of African Canadians. Her research focuses on inequities in health and healthcare, with emphasis on women's health, HIV and AIDS, nurses' work life, community health nursing, anti-racism, and the health of African, Caribbean, and Black Canadians using an intersectional lens and a community-based participatory research approach. Dr. Etoa leads international initiative examining and addressing the social determinants of health, racism, and health inequities. Dr. Etoa collaborates with community leaders, researchers, health service providers, and policymakers to create practice and policy changing knowledge mobilization tools. Her anti-Black racism work has resulted in sentinel contribution to the Canadian health system and bringing racism to the forefront of dialogues. Dr. Etoa, over to you. And I should mention, you're also an inaugural founder of this organization. So welcome. I'll turn it over to you.
Thank you so much. I do have a PowerPoint, so let me try to share that. Can you see it?
Yes, we do.
Okay.
Perfect. Thank you.
Thank you. I just had to use a PowerPoint because 15 minutes to talk about racism that I've devoted the last 3 decades to look at, it just doesn't do justice to it. It took me some time to figure out exactly what I'm going to share in 15 minutes. Because yes, we want to build bridges, we want to find national strategies, but we also want to constantly remind ourselves about the scope of this work we're talking about, the complexity of what we call racism and racism in nursing. Nursing that plays such a central part in healthcare, whether we're talking about the workforce itself or talking about the care we deliver. And so you would notice that I'm going to focus on reminding us of the scope of the problem, because it's only when we constantly name this problem that we can truly design interventions, that we can truly build bridges with the right pillars to anchor those bridges that would lead us to the equity we're talking about. So let me just spend these few minutes to again highlight that here in the Canadian context, racism has been increasingly associated with inequitable health outcomes for racialized Canadians. So Black Canadians continue to experience these poor health outcomes, and I know we've heard this over and over the last 4 years due to the systemic anti-Black racism. Public Health Agency of Canada acknowledges this. And I think that's one of the good things that the COVID-19 pandemic has done in terms of finally giving us a shared language to describe what we've been talking about for so long. Now we hear policymakers, we hear healthcare providers and different communities using the word racism. That was a word that many of us could not even put in our CV or even on research grants safely, because you would just be eliminated from that process because you are trying to point to things that doesn't exist. Even talking about anti-racism, I remember when I had to offer workshops on cultural competence in order to get people to the room. Then we can talk about everything else on the agenda, but racism will not be part of what you advertise. So various forms of discrimination intersect and experiencing these multiple forms of discrimination, whether it's racism, sexism, genderism, ageism, all combine to compromise care engagement and health outcomes. And now we actually know that racism on health is unhealthy for everyone. It makes us all sick. Evidence now shows that the psychological effort required to discriminate against another person can raise the cortisol level, blood pressure, and the risk of heart attack and stroke for those who actually are the perpetrators. So while most people may not be overtly racist, even passive racism or doing nothing to resist racism, just being a bystander in itself can harm more than just racialized people. And as I read this, I thought about even in my work with, say, white students, and remembering this particular student, a white student that I've worked with, and looking at these kinds of issues. And I remember us having a conversation about sometimes when we're talking about these issues and even just saying white people, it also brings anxiety in others. So the whole conversation about racism actually creates tension in others. And why do I point to this? Addressing racism is helpful for all of us. It's good and healthy for everyone. And I think that emphasizes the point that Zifa just made. So the strong evidence that spans decades and consistently point to race and racism as central in the health and well-being of racialized individuals, families, communities, and nations across the world. It's common knowledge now. In racism and race and racism have that deadly impact on the social determinants of health. And we know how these inequities in the social determinant combine to amplify those systemic threats to our health, especially the health of racialized people. We know that it does this through multiple pathways. One is how people live and maintain well-being while dealing with the burden of racism, and how socio-economic issues associated with racism continue to render people vulnerable in terms of both our physical and mental health. And I won't go into details of this, but we know the evidence, the strong evidence supporting how our physical health is compromised as a result of racism. Has long-lasting effect, whether it's on our blood pressure, our weakened immune system, our negative coping mechanisms, they're all linked. And the negative coping mechanisms which then relates to higher rates of smoking, alcohol use. So I just move on. In terms of mental health, we know we can link racism to these various mental health issues: depression, stress, anxiety, emotional distress, post-traumatic stress disorder, suicidal thoughts, and the list goes on. So we now all understand this. I bring it back to nursing because when I think about epistemic racism, and I deliberately decided not to get into my studies, specific studies, but this particular theme is a theme that came out of a recent study that we completed, a national study in Canada, the strange cases on the hallways of medicine, nursing, and other health disciplines is what we call that study. And one of the key findings is this epistemic racism, which refers to the knowledge systems and the rules about what we can know, what can be known, and the ways in which we consider the knowledge that is valid and how and who can be a legitimate and authoritative knower. These knowledge rules are often implicit and often tacitly racialized. So in Canada, the voices and knowledge claims of white Western scholars, researchers, and professionals have long been privileged. We know that white Euro-Western ways of knowing and forms of knowledge are legitimized and granted authority, while all others are rendered inferior. We also know that epistemic racism also means knowers themselves are devalued. How often do we talk about how nurses feel, or say Black nurses feel invisible when in other circumstances they are so visible? And I can recount from studies I've conducted of nurses just being passed for even the things they know. How often, even if the issue that affect them directly, we look for other people. A white nurse may visit Africa for 6 months and come back and be the one leading the initiative on how to help African nurses integrate in Canada. But a Black nurse who trained in Africa, worked there for many years, can come to Canada, work for many years, and never have the opportunity to lead an initiative to help others walk through the path through which they have lived in both worlds. That's what we're talking about. Building an inclusive healthcare requires that the knowledge claims upon which professional identity is granted be extended to all kinds of corners and knowers. We become more conscious of the opinions and attitude everyone brings into the workplace and the ways in which our mindset affect our behaviors. Individual differences are valued and each person feels included, respected, and fairly treated. That is epistemic racism, and I won't even bother going into this because Zipa has helped us to see that those differences I'm pointing to are not based on race. They are social constructions. They are social construction, and that's what we're talking about. Racialization is what makes race important. The process of being assigned a race with all of its subtle and not so subtle meanings, expectations, and assumptions, and results, and it results in people with certain characteristics, traits, and attributes to be viewed as being of a lesser worth or abnormal. Think about it in our nursing situations. Speaking with an accent, the manner of speech, your name, your clothing and grooming. I've done research with nurses who talked about being asked to show pictures those days, or in your application, there's a part where your name just makes you not to get admitted into the program. Hopefully that's not the case today. But those things still have implicit, informs our implicit bias. The diet, the beliefs and practices. I have spoken with nurses. I did 4 studies, a series of studies. First, grounded theory studies. One looked at Black nurses' work-life experience. The second study looked at other visible minority work-life experience. The third study looked at the work-life experience of indigenous nurses. And the fourth study looked at the work-life of white nurses in the context of diversity in Canada. And each of these studies points to the different ways through which racism is manifested in both our workforce in terms of diversity management, but also in terms of how we provide services. And some of these things will come up: diet. If your food smells a certain way, how do people react to you even eating in the lunchroom with other people? It can seem basic, but those things do affect your workplace and your ability to reach your full potential as a leader, as an effectiveness in bringing your full self in terms of your creativity and innovation into the workplace. So racism involves reserving favors, smiles, kindness, the best stories, one of one's most charming side, an invitation to real intimacy for one's own kind or class. That's why you may not be invited to that work party. That's why certain people may not be invited to where they have the discussion and the network that lead people to maybe know that there's a good scholarship happening here. There's an opportunity here for leadership growth. These kinds of racism or racialization creates those problems for us. So while structural racism and systemic racism are both pervasive and deeply embedded in laws, in policies, in practices, and established beliefs and attitudes that produce, condone, and perpetuate widespread unfair treatment of racialized people such as Black people, they have different emphasis. Systemic racism emphasizes the involvement of whole systems. So the political system, legal system, healthcare system, including the structures that constitute the frameworks for those institutions and systems. And structural racism emphasizing the cultural, the ideological dimensions, as well as the role of those structures, such as in laws, in policies. So for me, I see it as the scaffolding of those systems, the ligaments that connect both the individual level racist attitude to this institutional level and to the system as a whole. Because let's face it, when we're talking about structure, it's not only a particular system or structure. If an individual leader has a particular value, that value drives the organizational values. It drives what will be on the agenda. It drives what will be omitted in the agenda. And remember that the act of omission in itself, in the face of need, is discrimination. When you're constantly omitted from the agenda, even though there's a need, it is not important for that need to be mentioned in your institutional vision or mission statement and strategic direction. That in itself is discrimination. And it's part of the structures. So I'll just touch on the structure again. An example of structural racism, color blindness, those who claim they don't see color. That one should treat all persons equally without regard to their race. This denies the negative racial experiences of people and invalidates their unique perspectives. It ignores everyday racism, the microaggression, and examines only racism to extreme, explicit racism. So we have to take that into consideration. White supremacy is another form of structural racism, those values, and othering, using the power within the relationship for subordination and domination. I just wanted to point out some of the ways in which we see this, even in nursing, happening in our everyday practice. Because these, again, are those ligaments that ties those structures. So even when we're talking about structures, we need to think about those nuances in our interaction that ties those structures in place. White apathy. It is really sad that this is happening, but it's not my problem. So it's ignored. It's your problem because you're the racialized one. You're going to solve that problem. And so other people are too busy and would say, I wish I could help with your cause, but unfortunately, I'm just too busy right now. Unfortunately, I'm just too tired right now. Unfortunately, it's just not a priority for me now. Maybe when I can clear a bit of more space for myself, I can make some time to come and help you out with your anti-racism work. The white centering of white people, white values, white norms, and white feelings over everything and everyone else. This is the natural consequence of white supremacy. So when we think about white supremacy, we think of something out there. We're not thinking of the everyday interaction we see in nursing, in our workplaces. And so we need to think about this. Tone policing is a very common one where if Eurocentric people talk in certain tone, that becomes the norm. And so somebody who expresses emotion, whether it's about excitement or about other bad tensions, becomes something very unusual because it doesn't sound like the other one. Tokenism, get out of racism free cards, and white favorism. saviorism is the belief that people with white privilege who see themselves as superior in capability and intelligence have an obligation to save the racialized people from their supposed inferiority and helplessness. And I bring this to remind us that what we're tackling here is complex, and we need a multi-pronged approach. We need a comprehensive approach that addresses racism in its many forms and roots. And so the problem of systemic and structural racism remains a major gap that requires a comprehensive approach. It includes, and we need to use transformative approaches with critical race theory, equity, intersectionality to tackle the root causes of racism, its clinical in terms of mental health and physical manifestation, but also more importantly, policy intervention to dismantle this at multiple structure. Dami, am I okay with time? So here again, I illustrate the multiple level of the problem that we're trying to solve. I use this iceberg model to show that every time we're trying to address whether it's something at the individual or interpersonal level that happens in your workplace as a nurse, that we need to look deeper to the institutional level to say, how are institutions perpetrating or modeling what we need to do to address what's showing up on above the ice? This is the iceberg model. What we're seeing on the surface is just a small part of what is under the water, and even the deeper root causes, which are the structural and systemic pieces that informs our attitude, our beliefs, our morals, our values. And that's what really holds racism in place. And we need to dismantle it right up to those root causes. And so the role of nurses, I want to start with ethics. As healthcare professionals, nurses are required by their code of ethics to promote, advocate for, and to protect the health, the safety, and the rights of all people under their care. The American Association of Colleges of Nurses Future of Nursing 2020 to 2030 report clearly articulates the need for nurses and nursing school to include education and effort to address structural racism. Therefore, nurses need to be a part of a transformative agenda to address racism in healthcare and health workforce. We exist because there's healthcare, because people have health need, and that is why we exist as nurses. And so nurses are well positioned to tackle racism in its many manifestations in order to provide high quality care that is accessible and equitable to all, irrespective of one's racial or ethnic background. Nurses need to educate themselves. One of the strategies is it begins with us. We need to educate ourselves and the public about why healthcare must be re-envisioned through the lens of EDI, equity, diversity, and inclusion. The increasing number of EDI initiatives in the country is encouraging. However, we must move beyond just representation. Quite often when you look at this initiative, you can see diversity being. And I'm not even getting into the other piece, accessibility, justice. Some people would use IDEA. I use the EDI quick one that is so commonly used now. But quite often we stay on the first step, which is representation. Inclusion needs to happen. We need to see that they have actually targeted effort to ensure that as we recruit more people so we can see more diversity in the workforce, that we also integrate strategies to make sure that they are progressing through their career trajectory and getting into leadership positions, that they're not working in silos from those that have networks to move and grow into leadership roles. And equity really is the pinnacle of what we're looking at. When we do this right and measure it, then we'll be able to see equity in terms of health outcomes and equity in terms of seeing work career development among nurses. And so for the training program, nurses need to not only have the knowledge around attitude and awareness and sensitivity of the issues, we also need to be able to have the generic knowledge we need to transform the way we look at knowledge and to translate that knowledge into action. There are some programs that may focus on specific knowledge. I remember when we first started doing cultural competence courses or programs, you hear, okay, if you get a Chinese person, this is how you treat them. You get this person from this ethnic group or racial group, this is how you treat them. But that knowledge may be important, but more importantly, we need the generic knowledge that helps to build people's ability to transfer this knowledge, whether it's the way we communicate from scenarios to scenario, and not just because this person is from this race. And so right now, I want to encourage everyone. We have a critical health and racial literacy program at the University of Ottawa that will launch on April 2nd. That is a made in Canada intervention directed towards both providers and community members. And it builds on the model we're talking about, using multiple scenarios, including simulation modules, to educate providers in terms of how we do anti-racist practice. So investing effort, energy, and resources into undoing structural racism in nursing can unleash our collective potential as nurses and lead to new levels of innovation and nursing excellence. But it requires us to recognize that racial equity work is a collective journey, not a journey of those who are racialized only. One of the ways that I also created this transformative way of working is through the community-based participatory research approach, which is not only an approach to do investigation, but also a means of mobilizing people for collective change. It builds on the work of Paulo Freire, an educator from Brazil, the author of the Pedagogy of the Oppressed. And central to this work is the idea that we all have a responsibility to produce reality and to transform reality. And so we all need to analyze the situations we see around us, and we need to act to change the situation, irrespective of our position in that particular situation. And so in conclusion, structural racism is everyone's problem and calls for an interdisciplinary and integrated transformative approach. We must look for common grounds and areas of synergies to install the pillars necessary to support the bridges to health equity. When we design anti-racist systems and programs with the most marginalized people in mind, like Black people, the system works for everyone. For example, closed captioning helps more than just those with impaired hearing. Cop cuts helps more than those who use wheelchair. Like young mothers with babies in strollers enjoy those cut cuts. So similarly, anti-racist nursing profession can be healthy for nurses of all races and ethnicity, and we must all make it our work. And finally, to advance anti-racism in nursing, we must develop and implement system-level policies and practice intervention in the areas of funding, workforce diversity, especially in leadership, research in nursing, data governance, and accountability measures for the equity work. So I'll stop there. Thank you. I acknowledge those who fund and support and work with our team on project.
Okay. Thank you so much, Dr. Etoa. I can't even begin to dissect what you just said, because there's just so many things that resonate with me. I think one of the biggest things that I will say is what you said around, look, this impacts all of us. And so it is really all of us responsibility to take action. So I see that Dr. Chapman is online with us, so I will keep my comments brief, but just know that everyone, all of you can put questions in the chat, which will be looked at later for any of our presenters. So thank you so much, Dr. Etoa, for that amazing overview and comprehensive look at racism and how it is impacting not just nurses, but the people and communities that nurses are serving. So thank you. I would like to introduce our next speaker. Dr. Lee Chapman who is our Canada Chief Nurse Officer. is committed to advancing the nursing profession in Canada to ensure an equitable access to quality care. As the CNO for Canada, she provided strategic advice to Health Canada, plays a convening role in key nursing issues, and represent the federal government at public forums. Dr. Lee Chapman is a registered nurse who received a PhD from University of Toronto's Lawrence S. Bloomberg Faculty of Nursing. Excuse me, a lot of words. Over the past 20 years, she has gained a deep understanding of nursing by working in both frontline and clinical leadership capacity. In addition to her role as CNO for Canada, Dr. Chapman continues to work at a community-based consumption and treatment site in Toronto, where she provides harm reduction services and frontline care. Thank you so much, Dr. Chapman, for joining us. I turn it over to you.
Thank you so much. Merci beaucoup and bonjour tout le monde. Happy Nursing Week to all. I'm absolutely delighted to be here, and I'm sort of double booked today, so I was only able to catch the tail end of Dr. Atowa's presentation. Apologies. But I have to say Dr. Atowa was at my appointment day when I was appointed into the role, the announcement at the University of Ottawa, and it was wonderful to see you there in the crowd. I think I probably looked like a bit of a deer in the headlights on that day of my appointment. It was my first ministerial announcement. So wonderful to be here. And this is such an important topic. I really love I caught when you were talking about white supremacy in me, which is really kind of required reading for everyone in Canada, but certainly for all of us in the nursing profession, and the notion that this is our collective responsibility. And I think that is the spirit with which I try to lead from my standpoint as Chief Nursing Officer. This is something that is this topic is really foregrounded in all of my remarks, all of my presentations, and something I try to really shine a light on. So I'm going to talk fairly briefly because I know that you're all also very excited to hear from our colleague across the pond, as we like to say, Angela Knight-Jackson, and I've been super impressed with the work that she's been leading over at the NHS. So I don't know if I have control over the slides, but maybe if you can advance.
Sorry, I think you do.
You can request. You can request, and I can give you control.
Oh, look at that. I don't know how to do that.
Don't worry. I will advance the slides for you.
Thank you. I'm so sorry to be very
no worries.
Well, I just want to also, of course, reiterate Happy Nursing Week to all of you. You may not know this, but every year our National Nursing Association, which is CNA, has the choice to go with the theme of the International Council of Nurses or to choose their own theme. And this year, CNA chose their own theme. And I love the theme around changing lives and shaping tomorrow because I think it's so appropriate. I often talk about nursing work as being legacy work. We have the ability to influence people's lives and to touch their lives every single day, regardless of the role in which we lead from. And certainly shaping tomorrow, nurses have a key role to play when it comes to the health system transformation that's needed in our health systems across the country. So we'll go to the next slide. Damilola, you're far too qualified to be advancing my slides, but thank you. I appreciate it. I wanted to just highlight some sort of policy commitments. These are shared federal, provincial, and territorial health ministers' commitments that were agreed to in October of last year at the federal, provincial, and territorial health ministers meeting. They do meet more than once a year. It's just once a year where we all meet in person. And so these are 5 shared priorities that I think it's important to highlight that we're all sort of collectively working towards. So one is around retention, and I'm going to be talking about the Nursing Retention Toolkit. But the specific commitment from the ministers was that they agreed to support the dissemination and implementation of the toolkit, which I think is very promising and positive, because we know that retention is not cost neutral, that it does require focused investment, and is really the strategic reorientation that we need in our health systems. And the language as well around reducing rates of stress and burnout and improving workplace culture, flexibility, and wellness so workers can stay in their jobs. And I think that speaks to the multitude of issues that are impacting the nursing profession at present. We are also undertaking a supply of domestic education and demand, knowing that nursing education seats have been added in most jurisdictions across the country, but seats does not always mean graduates. And we know that when the service side of healthcare is strained, so too is the education side. And we need to absolutely support students and have a better sense of how many nurses we actually need in Canada, how many are needed now and for the future needs with our aging population and the increased chronicity of illness and increased acuity as well. And then also looking at training opportunities for Indigenous people who are very underrepresented in our health human resources. We are also looking at foreign credential recognition, working with immigration services, and ensuring that we actually have an expedited pathway for integration of our internationally educated nurse colleagues, as well as a Canadianized version of the Global Code for Ethical Recruitment. As a member state of the World Health Organization, it's really important for us to adhere to this code. And so we need to have an understanding of this within our federated model of Canada. Labor mobility, nurses are very keenly interested in having an agile and flexible workforce. Many nurses work across jurisdictional borders, and so we need to be promoting labor mobility across jurisdictions, knowing that it doesn't actually increase the net number of nurses in Canada, but it does improve their flexibility and their nimbleness to respond to various health emergencies. And then health workforce data and planning also is a key piece. And I would be remiss if I didn't highlight the collaboration between CBNA and PCNAD in some of the work that's being done on health workforce data and planning, such as Ontario, the College of Nurses of Ontario's work on a workforce census to try to get better race-based data and a better understanding of the composition of our nursing workforce, at least in Ontario. And hopefully this work will follow in other jurisdictions as well. Okay, so we'll keep going. The toolkit, which I mentioned, is really, I think, a great example of pan-Canadian collaboration. We brought nurses from across the country together in June of last year to co-create the Nursing Retention Toolkit. And we included several nursing experts, point-of-care nurses, nurse employers, decision makers, nurse regulators, union representatives, and others, and really tried to highlight and center diverse perspectives, because we know that, it's often, there's often a cappuccino effect, I think it's often referred to, that nursing leadership tends to be very white, and we absolutely know that we need that diversity within leadership. We need the diversity within the Canadian population to be reflected in our nursing workforce, and we need that support to exist. And we need, obviously, to eliminate racism, which is really the topic du jour today. So this Nursing Retention Toolkit is a resource created by and for nurses, really focusing on nursing practice in the clinical environment, in the domain of clinical care. You can see here 8 themes in a color-coded circle. We put them in a circle in a wheel because we really didn't want to convey a priority over any particular one. But what I think is really key is that the themes are underpinned by the values of respect, transparency, anti-racism, anti-oppression, and accountability. And so those values are threaded throughout all of the themes. And we really wanted to make that explicit in the toolkit. So I'm just going to highlight on the next slide just one of the themes in particular that I think has some relevance to this topic. So if we can just go to the next slide. Perfect. Thank you. So under organizational mental health and wellness support, so the goal and all the themes have a fairly similar structure, that there's a goal statement and then there's 2 to 3 initiatives. This particular theme has 3 initiatives. So the goal statement under organizational mental health and wellness supports is to increase timely and fulsome access to appropriate and effective preventative and acute health and wellness supports with an urgency and focus on mental health supports. So I say this with a couple of caveats. One is a reminder that the thread or the theme, this is one theme of 8, and the values of respect and anti-racism, anti-oppression, and accountability are threaded through all of the themes. So this is one where we kind of hover on this topic, but I think it's threaded throughout the entirety of the toolkit. Under this particular initiative, where we have highlighted zero tolerance for violence, bullying, and racism. So one of the things we highlight, I guess, is that we made changes to the criminal code, or the federal government made changes to the criminal code during the COVID-19 pandemic. And this was around Bill C-3. So this was a policy, essentially a change to the criminal code around protests that were happening, impeding healthcare providers' access to their place of employment. Mainly anti-vax protests, but you can absolutely see how this bill and the changes to the criminal code would actually have implications for things like gender-affirming surgery, access to abortion and reproductive rights, and so on. What I have found in my engagement with nurses across the country is that there's very little awareness of this bill and these changes that were made, and that there's a great deal of violence, bullying, and racism that actually happens within healthcare organizations, and very little enforcement. And so it's very clear to me that we have a lot of work to do, and this is why we put this as an initiative in the toolkit. We also highlight 3 great examples here, and I think I urge you to visit the Canada.ca website, because there's a lot more great detail there on the website. But these are 3 examples that we've highlighted. The Collaborative Nursing Declaration Against Anti-Black Racism in Nursing and Healthcare. And this was a collaboration between CNA, CFNU, CBNA. It feels like a bit of an alphabet soup whenever I say that, of nursing organizations in Canada, but PCNAD was, of course, part of that. And this is where all various nursing associations join together to create a nursing declaration. And we think that this is a very powerful collaborative statement that can be referenced by healthcare organizations across the country. We also highlight the Canadian Association Schools of Nurses Promoting Anti-Racism in Nursing Education in Canada report. And I know that the Canadian Association Schools of Nursing is really trying to do more work in terms of anti-discriminatory pedagogy, providing culturally safe context for learning, and so on. I love that Dr. Itoa highlighted Paulo Freire and the sort of critical race theory, and how that really needs to be integrated into nursing education. This critical race theory and pedagogy is key to ensure that we are actually educating nurses appropriately to be anti-racist in our healthcare system of today and tomorrow. And then we also highlight the 50-30 challenge, which is Your Diversity Advantage. This is an online tool for organizations to implement, to look at implementing EDI practices across Canada. So just a couple of examples. There's a lot more in the toolkit, but I just wanted to highlight those things that are highlighted in the toolkit. And we'll go to the next slide. Perfect. And that's the end. But I really welcome the discussion and want to really applaud PCNAD. It's been my honor to collaborate with you since I've been in the role as Chief Nursing Officer. And I think that, the work that you're doing is essential. We have expertise across the country that we absolutely need to rely on in advancing this work. So thank you very much. And I welcome the discussion that follows.
Fantastic. Thank you, Dr. Chapman, for that amazing presentation. And I do urge everyone to take a look at the toolkit on the website. You just need to go in your favorite search engine put it in, and it will pull it right up for you. So thank you so much. So our next speaker is Miss Jackson Knight. And Miss Jackson Knight is a national leader in England, responsible for the leadership and management of nursing professional development. She is actively engaged in developing a strong group of nurses and midwife leaders to deliver the NHS lead long-term plan, ambitious and system transformation. Miss Jackson Knight's portfolio of work includes the development of senior nurses in the transition to the integrated care system landscape and executive development, commissioning innovative and groundbreaking nurse development programs with internal and external partners, in the delivery of the first national CNO and CMO ethnic minority action plan. Ms. Jackson Knight is energized by growing leaders in healthcare and is a leadership associate at NHS England and an executive coach and mentor. In June 2022, she was the nominee or recipient of the Platinum Jubilee Queen Elizabeth II birthday list that gave her royal recognition to the incredible public service of nursing staff and other healthcare providers or professionals across UK. Ms. Jackson Knight was awarded an MBE of services to the NHS and in particular the nursing and midwifery workforce. And I apologize, I think I said Jackson Knight is Miss Knight Jackson. So my apologies for that. My apologies.
Thank you very much. Let me see if I can share my screen. It looks like I can. Great. Good. Hopefully you can see my slide. I will say that there are just 2 slides. What you have to do is just listen intently. It's a real privilege to be here, and thank you, P. Canad, for inviting me, and more explicitly, Damilola. It's certainly been a journey connecting with P. Canad, and I thank Dr. Lee Chapman for the initial introduction to this really amazing group. I also like to thank the previous speakers. I think it's Ziffer. Love the idea how you talked about racism and the 2 points in time where the publications increased. And interesting, the second one was the year 2020. Thank you, Josephine, as well, for your perspectives in inequalities in health and more importantly about racism. And of course, Dr. Lee Chapman in relation to the work, what you're doing in and across Canada, but also for that toolkit, the retention toolkit was just being developed. That was no mean feat, and I can just imagine get everybody in the room. And I'm sure there were a lot of divergent ideas, but you coalesced them so well to produce what you've done. I think what I want to start with today is, personally, this iceberg, what Dr. Etoa talked about, you know, because you have that individual, and then she talked about community and system. So I'm going to talk, first of all, individual, and then locate that within a system. And so what I'm going to start with is my personal story. This story is, I hope, will not be seen in Canada, but I suspect that it might have been. In this particular point in time of my journey, I want to tell you about when I was stuck. hook, line and sinker. I don't know if that's a British term, but yes, hook, line and sinker. I was stuck. There was no way out. I was blocked. I had the relevant qualifications. At that time, 2 masters, done all my nursing, clinical qualifications as well. I had undertaken leadership courses. I was a coach and mentor. But I think because of the whole gamut of all the work I'd undertaken, I realized I was stuck. I tried the interviews. Again, what would come back is somebody just picked you, or something like you didn't answer the questions fully. I tried the conversations, you know what they say, around the networks. Nothing was happening. Our professional development portfolio, so when we have that development conversations, which in England we have once a year, and then we work towards what development you need. I'd had them, and yes, I was a really good practitioner. However, there was no indication that I could be moved into other posts or jobs or development. I actually began to feel dejected, and I suppose I'd resolved myself that this was my lot and I could see no way out. In fact, what should I do? What would you do if you know that you are being blocked or that you're actually just stuck? Well, it's interesting because of my background in coaching, mentoring, understanding the need for leadership development. I actually knew what I wanted. But how was I going to get it? You see, at that particular time, I was in the medical directorate. And so what I needed was a bridge from medicine back into nursing. I'd read and heard about a course. It was the Florence Nightingale Foundation course. I'd looked at other people's experiences. I'd seen how they'd been developed. But although that fire was in me and I was ignited by this course, when you're being blocked, it's very difficult to actually go to a line manager and say, this is what I want. So how do I do this? And the obvious thing I'm hearing from the screen is, well, don't you just apply? I hear you saying apply. But when you are stuck and when you are blocked, how do you do it? Well, what I did, I applied some perceptual positioning. I had to think about, so the course, the 3 levels was the senior leadership, there was aspiring directors of nursing, and then, of course, there was emerging leader. So I had to think about, how does my line manager, my senior, see me? I'm not saying that's where I was, but I had to do that fly on the wall. What is their thinking? And so I did use the fact that if I went to apply for a director of nursing, aspiring Don's post, director of nursing, it wouldn't happen. So what I did is I actually applied for an emerging leader, because I thought, actually, that's where my senior leaders see me at the moment. Well, needless to say, I got onto the course. And it's interesting, on the first day, I was just doing what I normally do, and that is engaging with the conversation with the speakers. Then in the afternoon, we were then put into our groups, and I, of course, went into my emerging leaders group. And surprise, surprise, the lead for the course, the CEO for the Florence Nightingale Foundation, looked at me and she said, you don't belong there. You're not an emerging leader. She said, go to senior leadership or the aspiring dons. That's where you should be heading. And I thought, what, me? Somebody's actually seen me? And you know what? What transpired was a whole new life for me. And this happened in 2019. I'm going to pause for a moment there and hold that thought. Okay. So you may say, what a wholesome story. And it was. And you haven't even got to the end yet. But sadly, I'm not sure if it's the same in Canada, but certainly in England, not all persons of colour in our workforce have this story and are enabled. This is because, and dare I say it, racism. Now, what helped me in my journey and in that particular moment was probably a number of things coming together. But today I just want to focus on one thing, and this is the systems bit now, and that is about data. So in England, what we have is something called the Race Equality Standard. The Race Equality Standard has been available since 2015. The next slide has got all the resources on there and you can click on. It's an open document. And within that, within the res, it talks about, so we've got data now from 2015 right to 2023. Sorry. It's an annual exercise where all the providers, we call them trusts in England, they would come together to complete a survey on for the Race Equality Standard. Within that, so this is across England, within the standard, we now are able to show the percentage of staff who are of colour, Black, minority, ethnic, or some people say ethnic minority or minority ethnic, across the providers. We can do that at executive level. And we also ask questions around bullying and harassment. So why is this important? Why is that particular data important? It's why, because we know that equal access to career progression is not necessarily afforded to those people of colour. It's needed because we need fair treatment in the workplace. Workforce race inequality, again, the evidence is there, and provides an adverse impact not only on our workforce, but also on our patients. And what has the RES data given us? Well, what it has is given us the figures. So we know how many people from ethnic minority backgrounds are in senior positions. We know how many are and what that trajectory has been over the past 5-7 years. We also see that there is a skewing of the data for the lower bands. So we find that, particularly nursing and midwifery, they are skewed in the lower bands, and yet the further you go in the bandings which lead to executive level, there are fewer people representations from Black, minority and ethnic communities. And so that has afforded us the opportunity to do a bit of the how now, because we're supposed to be able to see the dial turn as we start to implement various strategies. So, for example, one of the strategic targets a couple of years ago was an aspirational target that we want to see 19% representation across bandings, across pay scales, from the lowest bands right to the upper bands. We also have plans, just like yourselves, in terms of the CNO and CMIDO. CMIDO is Chief Midwifery Officer, Ethnic Minority Action Plan, which has now been superseded with last year. We're now looking at EDI, Equality, Diversity Improvement Plan. And within those plans, there's an accountability now to the board, where they also need to look at their figures within their organisations around equality, diversity and improvement. But one of those is, of course, race. And so each board within the provider organisations will now start to report on improvements. So accountability is so important. We had the statements around BME, aspirations, EDI, etc., but now what we're trying to embed is the accountability for organisations to deliver. And this also includes the individual organisations as well as the regions, which you would probably call provinces. Some of the things I've been involved with in an operational level will be one of the keys to unlocking career progression is around this leadership acumen. We, as people of colour, are often focused on a lot around the academic side, but the leadership side, the softer skills, is so important. And that translation from national to regional or province to local and individual, that strategic thinking, leadership development and courses will help that. So we're looking at the talent pipeline for deputy directors of nursing so that they can move on in their career. We also, that's linked with a higher education provider or a university. We have executive director programs, which are for all aspiring board members. But what we have done is looked at the composition of those people who go on to these executive director pathways and to ensure that there's equal opportunity. So, for example, our first cohort, I think it was 50%, which is more than the average of our workforce. Which went on the course, i.e. from a BME background. We've also held a symposium. The first symposium was just before lockdown. And again, with that res data, what it showed us, we could count, and I think it was approximately 150 BME nurses and midwives who were above a certain banding, so at the senior bands. So a symposium, we actually got them in 2020 in a room and started to talk about the issues. What is it? How can we move forward? And since 2020, we've had a symposium every year talking about successes. How many people have managed to progress in their careers? What is the res data saying about moving into executive positions? We've also had a program which was for clinical fellows. Clinical fellows, it was advertised nationally. This brought our nurses from across the nation into the national nursing team and in different particular arms of our professional system leadership team. And then we were able to work with them so that they got a picture of that national policies, national drivers, and how that's translated, so that as they go for roles, you know, sometimes people say, oh, there wasn't enough strategic thinking. Well, we're giving people the opportunity to have strategic thinking. We work closely with all our networks, just as P can add. We have networks, male networks, we call them Jabalim networks. We have the CNO, BME SAG network. We have our networks for and diaspora groups around internationally educated nurses. And so this is a practical example of how we're moving and working with our workforce to actually turn the dial on those figures. The other thing what we're doing, which I think was alluded to, is talking. It's important to talk about discrimination, about having an anti-racism approach, and not shy away. So we're trying to create safe spaces for our senior leaders who are often white, who may feel uncomfortable in this space. And one of the things we launched, I think it was 2021, was around 2022, was the Combating Racial Discrimination Guide. This is basically, it's an anti-racism resource. We worked as a tripart group with 3 organisations, NHS England, the NHS Confederation, and the Nursing and Midwifery Council. So here we're trying to influence the actual code of practice for nurses. We've got the resource. It's now disseminated across England, and we want people to use it because it talks about what happens if you experience racism. And what if you witness it? What are the resources available to you so that you can go to somebody to talk about it, and more important, that it's acted upon? The resource also, as I said, because the regulatory body is involved, we hope to influence and have some statements within the code so that each registrant is individually accountable to their actions and how they become an anti-racist practitioner. So that's just a few of the examples Damilola wanted me to talk about, and the so what, how have we implemented it in the UK. So we've looked a little bit on systems. Let me come back to my story. And it's important. Stories are important because it's only by sharing your story you can help to dispel some of the myths, what Dr. Eto'o was talking about in terms of how we are stereotyped. So here was I'd just been moved from the emerging leaders group and actually ended up in the senior leaders group. And what happened? Well, if I could have seen the future at that point, what if I had seen that the very training in itself was so insightful? Not only was I with my colleagues, but also we went further in terms of the system. We went right up to Westminster, which is the seat of government, where we were able to look and observe and to network in that field. We were taught how to talk and how to speak and how to breathe correctly. We were able to share personal journeys. What if, when I was sat there, when I had been moved, I'd realized that my mentor for the course was going to be the first chief nursing officer for England. What if at that time I recognized that COVID was about to hit us and I would develop the first national ethnic minority action plan? What if I at that time had known that I was about to develop the first national senior clinical nurse fellows program, which would bring in not only our white colleagues, but also a significant proportion from our ethnic minority groups? What if I had known that from that medical directorate where I was stuck, I was about to be catapulted into the national nursing team, and become a national lead? What if I had known that I was going to be named in one of the Queen's Award, the late Queen's Award, Elizabeth II? What if I had known that I was actually chosen to attend the Queen's the Queen's funeral. I think racism is a disease, a societal disease, which is multifaceted. And behind each of those racist incidents, there is an individual, such as me, such as you, who is waiting to burst forth and deliver the excellent care which we can deliver, not only to our patients, but to our communities, to our systems, and to our workforce. And now we're in Nurses Week. Let us think more aspirational, but also may the systems be untangled and broken, and may accountability come in so that we, as representatives of colour, can contribute in a significant way to deliver quality healthcare in whatever country we serve. Thank you.
Thank you so much. Thank you so much, Ms. Knight Jackson. I really apologize for reversing your name in the beginning. I do have dyslexia, so it rear its ugly head every now and then, and my sincere apologies for that. Thank you so much for that very compelling presentation. You hit on a lot of things that, in fact, CNA, the study that I referenced earlier that we are leading, we just completed the third phase of that study, sampling over 3,000 nurses in Canada. And a lot of the things that you're talking about were actually similar themes that we are identifying. So not going to steal CNA's thunder by releasing the findings right here, but those will be published soon. But I really liked your personal story. And I think, I think you made the reference that maybe that's not the case here, but there's comments in that chat just saying that those stories are very resonate with a lot of people here. That notion of feeling stuck, and imagine, nurses feeling stuck and then each day going into the workplace and being expected to perform at their best, right? Yeah. So I'm really excited for that results to come out, and maybe we can have another webinar and have you come back and help debrief all of those things together. So we have now come to our Q&A section, part of our webinar. People's microphone and cameras, I'm told by my co-host here that should be coming on now. So people feel free to put your questions in the chat, or you can unmute yourself, raise your hand, unmute yourself, and ask the question. We do have a question in the chat. So maybe we'll start with you, Dr. Chapman. There is a question in the chat that says, could you elaborate on how federal funding is being utilized across provinces to bolster the implementation of best practices outlined in the toolkit?
Oh, that's a good question. So essentially, we released the we've released the federal budget a few weeks ago, but last year with the announcement of the Working Together for Canadians plan, there was an announcement around the record investment in healthcare of over $200 billion. And so those agreements between the federal government and the provinces and territories have now all been signed, the bilateral agreements. And so it's through those bilateral agreements that the funding flows. Federally, we fund healthcare. How it is managed and administered is up to the provinces and territories. And so that is essentially the investment that's focused on health human resources. And I would say that some jurisdictions, some provinces and territories are focusing more or less on health human resources, depending on what they're already doing. Some jurisdictions have very strong health human resource plans. Some are focusing on more health and social services. And so it is a bit of a I sort of say it's not one size fits all across the country. Different jurisdictions are doing different things, but even in jurisdictions that are perhaps not focusing on broad provincial or territory-wide implementation of the toolkit, organizations are also picking up the toolkit and implementing it. So it is happening, I want to say from like macro to meso. I don't want to say at the individual level, because we know that retention is not about individual nurses, doing yoga or having a bubble bath. It's a structural organizational change that's needed. So even in jurisdictions where there isn't sort of a focused commitment on nursing retention, they're focusing on other things in their bilateral agreements. Many organizations and health authorities within those jurisdictions are implementing the toolkit. So that's around the money, and often organizations or employers will say to me, well, where's the money, and how do I start, and how can I spend this money? Well, they're already spending money on vacancies, filling vacancies, on travel nursing, on agency nursing. The money is already, and on poor patient outcomes ultimately when you don't have robust health human resources. So there's money and there's commitment.
Thank you very much for that. While we're waiting for others to think of a question, I do have a question, which, we all know that, at least from all the things that have been said so far, that racism has existed since the inception of this country. And so, and obviously it has existed in nursing since then too. I'm wondering if any of you can share some light in terms of why do you think that it has taken this long for action to be taken, right? So I'm always curious by the fact that, at least here in BC, there's been a lot of advocacy work of collecting that race-based data, right? Which is like pulling teeth to do that. And yet when I go into some systems and other places, I am forced to, disclose or to state my pronouns. And nobody seems to want to see or ask me if it's okay for me to want to do that. So I'm just curious why we're having such a difficult time in collecting the data to show that there's racism. And yet when we see other types of forms of discrimination or other forms of interventions to sort of create equity within the spaces that we're in, it doesn't have the same sort of contentious debate around it.
I mean, I can jump in, but I certainly am well, I welcome the perspective of my colleagues. I think that from our perspective federally, we're very interested in knowing that the composition of our nursing workforce reflects the diversity that we have in our Canadian population. So the data is needed. I think from the data is regulatory in nature, and so it's making that link between why the data need to be collected and how it impacts patient safety. Because the regulatory mandate is around public protection. And yet, so we know that, the public is certainly harmed when it comes to racism, and there's examples of that. And, speaking to your earlier comment, every institution in our country is has a colonial basis in racism. So it's not just healthcare; it's everything. It's decolonizing and confronting racism in education, in healthcare, in really every institution as we know it, in government. There's a lot of work in government going on federally, but I think it's also when the data are collected, then it requires action. It requires subsequent follow-up and action, and so it's a multi-pronged piece. I think it's making the link to patient or public protection, but healthcare providers are also patients. And so we need to really deconstruct this notion that the data is so important in informing planning and policy. And, there's so many examples of how racism creeps up in healthcare, how it's very prominent, I think having the data is key.
Yeah, I would second what Lee has said. It's a societal ill. It's across all systems, and have the data, but then it's the action from the data and the monitoring to see if there's are there any changes and how you move forward. Certainly, it's embedded through colonialism, and to unwrap that layer, if you think about an onion and you're taking off skin by skin, layer by layer, and even when you get to the core, there will still be dissent. And the other thing is that you're not be realistic. Not everybody will be on board with this. But what you can do is work with those who are on board. And another perspective, what came to me the other day, and somebody talked about it, is that when our white allies stand with us, sometimes it's at a cost to them as well. And so there can be a reluctance to come forward because there's ramifications. You see it with the woke agenda, etc., etc. So it is complex. What I try to do is, if I think about the huge agenda, as I've said, what I've tried to do and present to you today is my influence in what I can do where I am now, working with the leaders who I lead with as well.
Dr. Etwa, any other comments to add to that? Sorry, you're muted.
No, I'm good. It's great. I think we've addressed many things. Thank you for your leadership in bringing us together.
Mm-hmm. Yeah.
Thank you. We have another question or hands up from, is it Essie?
Oh.
Yes, that's Essay.
Essay, sorry.
Yeah, that's fine. That's okay. My name is Essay. I'm a nursing student actually. I'm in my third year, and I have a question to. This question is addressed to, with all due respect, I don't want to mention her first name, Etoa. Is that Mrs. Etoa? Is that okay to address you that way? Okay,
It's
yeah.
fine.
So my
Yeah.
question is to Mrs. Etoa. So I heard when you mentioned something about color blindness, like not seeing the color, like it's so personally, I have my story obviously, right? But personally, moving to Canada from Europe, I lived in Europe for about 10 years before coming to Canada. I intentionally chose not to see color. Not because I want to underrate anybody or say, oh, I don't know this person is black or this person is white. That's not the intention. It's for my own sanity. Like I tell myself, I appreciate everybody. I love everybody just the way you are. And most times, even in clinical, some of my friends will come and say, oh, Essay, can't you see that how that white lady is behaving? I'm like, really? I'm not saying it. I'm just here to do my job. And that's it. Right. So when Mrs. Etoa mentioned about the colorblind, maybe I'm a little bit naive. I don't know exactly what she meant by that. Like, is it a bad thing to be intentional about not seeing the color? Because for my own sanity, I chose to follow that path. I just want to see humanity, not color. So I don't know if you get the question I'm trying to ask. Thank you.
Thank you. Thank you. I think I do. And from what I shared with you, you just said that was an intentional decision. So it's a coping mechanism. It's probably working for you not to think about the whole issue, but not recognizing color like I speak about is actually a negative coping mechanism because it can actually create more problems because you're not acknowledging it. In your role where you work, acknowledging what you're seeing help to address some of the issues we're speaking about. Because whether or not individually we acknowledge what exists, the problem continues and it just grows. If we don't name it, we cannot address it. We have to name it before we address it. Can others add to that? I'm sure we all have perspective on the use of color blindness?
I think there's a book called Nice Racism. And if you look into that book, and I didn't think about it until I read it, was not acknowledging color. I think they talk about by not acknowledging color, then you are actually, I don't want to use the word disrespect, but you are also not acknowledging, that's the word, not acknowledging the experience, the history, and the struggle what somebody of color has to live with in this current society. So I would prefer somebody to say, I see that you are black, rather than, oh, I don't see color. Because I think if people start talking as a woman, to me as a woman of color, I'm hoping that they're recognizing all the package what comes with that living in a society. That might be a
Yeah.
book to think about. Nice Racism. It's a really good book, good read. I can't remember the author, but it's a very good one.
Yeah, and if I could add something, essay, I'm with you, and if someone is socialized differently in an environment where everybody sees everybody the same, and they are in another environment where they sometimes do not experience maybe racism, because we have to talk about Black privilege as well, which also exists, right, in our community. Some folks within the community experience racism differently, and some because of where they're situated may not even, like, in quote, like, experience it, or maybe not experience overt racism and feel as if it does not exist. But that doesn't negate the presence in the structure, in the fabric of the society, right? So, like, some people use that because they haven't experienced it. Like, I have folks in, my circle, when we talk about anti-Black racism, like, yeah, I'm Black. Nobody treats me differently. I have white friends. I have, my dad is white and we all get along well. And in another cycle, people talk about, I go out to the store every day. When I'm talking with my nursing colleagues, it's hard. So same people, or maybe same group of people based on the social construction of race, based on, their skin color, but different experiences, right? But it does not mean that it's not present. Ideally, as a society, honestly, we want not to see color when we respect everybody and see every human as human. Right? When you go out, everybody just treats everybody nicely. But unfortunately, that's not the history. That's not how the systems are structured. That's not how, like that's just not the case. And to move forward, to really envision a way forward, which we're talking about today, we have to first talk about our differences before we can talk about our similarities and see how we can work together as one. So I hope that answered your question. And I want to quickly say that we are like 8 minutes behind, like we are done, but I know people are still in the room. So if anybody wants to log out, and I know Dr. Chapman, I think, needs to jump off to another meeting. If anybody wants to leave, please, you're welcome to, but we just want to give people this opportunity, to engage if possible. Yeah. So, Essay, I don't know
Yes,
if that
I see
answered your
hands
question.
up.
Well,
Yes.
I
yeah,
see
in a
some hands
way,
up.
Yeah.
yeah.
Essay, go ahead.
Thank you. Yeah, thank you so much for all the contribution. I really understand what you all are saying, right? The truth is that I have experienced it. In my clinicals, a patient called me a slave. I cried my eyes out. I reported to the faculty, and I was so happy the way my faculty actually handled the situation. So it's not like I haven't experienced racism. I have experienced it firsthand. But like Mrs. Etowa said, it might be a negative coping mechanism. But for my sanity, I just want to not that I don't see color. I personally, I identify as a Black woman, and I am proud to be a Black woman, right? And if you're going to treat me in a negative way, for me, I feel that's your problem. It's got nothing on me because I have trained myself in such a way that I have to respect everybody as a human being, not because you're white or you're brown or you're yellow or whatever color. Even the Indians, I respect everybody. So I hear everything you all are saying, and I'll take it on board. Thank you very much. Yeah.
Yeah. Danny, I just wanted to say one quick thing because what she just said is so powerful. It came out in my PhD work studying Black nurses. When that thing first emerged in my work, I was confused. I said, this person is a Black person. Even the person transcribing that person's story was like, is this person in another planet? Like, because she somehow coped with racism by just saying it doesn't exist. And that's where I came up with the concept of passing, identity manipulation. Like you pass, because that's how you cope. This person led to nothing, went to another field and did really well, and doesn't ever acknowledge that racism existed in nursing and just speaks about it differently. I had to use the work of a Gosman from New Zealand to help me understand that identity manipulation, the process of passing. But anyway, it's so this discussion is deep, and there are so many ways we can tackle them, and I'm happy you're starting this journey for all of us. Thank you.
Thank you so much. We do have another hand up, and I'm going to butcher your name, so I'm going to let you unmute and ask your question. Is it
I
Bisi?
can help you. Bisi Oyelano. Yes.
Bisi. Okay. I was close. Bisi, are you able to unmute?
Okay. I think, can you hear me now?
Yes.
Okay, thank you for giving me this opportunity. Actually, I am fortunate to be a part of this event today. Currently in Jamaica, but when I got the invitation, I said I need to attend this because I'm so passionate about the topic. My name is Bisi Oyelana. I'm currently working as assistant professor at the Mackinwell University, Edmonton. So the conversation is really interesting and the presentations. So why I want to contribute is because of the last speaker that asked the question about, being color blind. I think many of us are using that approach as our coping mechanism, but it could be very frustrating because I believe that if we don't acknowledge racism, if we don't call it out, how do we address it? Like Dr. Edgeworth said earlier, how do we address it? But many of us, we find ourselves using this coping mechanism. We pretend as if it is not there and we are suffering in silence. But the issue is some people that are ready to call it out. When you see your colleagues denying it, it becomes very frustrating. It is. Because I see myself as somebody who I am fortunate to be in the role that I am in right now, for me to be able to be advocate for my students that are passing through racism, because my heart bleeds with them. I cry with them most of the time. But if I myself, I cannot call it out when it's happening to me, how will I be able to, to speak on behalf of my students? That's what I struggle with. How do we get there to the level that we are able to call it out that this is what is happening and it should not be happening? But we are afraid of the consequences. The consequences that we will face, because when we are facing the consequences, we are left on our own, no support, even from our own colleagues that are supposed to join. And I don't blame them. It's because they too, they are afraid of the consequences that they are likely to face, calling it out. So if we are asking the question, Why is racism continue to flourish? Why does it? Why it has been existing from the beginning and is still flourishing? These are the reasons. We know that this is happening, but we are afraid to challenge the situation. And when we are not able to challenge the situation, people just continue to do what they have been doing. So how do we get to that level where we will have the courage to say, okay, I don't like this. At least I'm not hurting you, but you are the one hurting me. Do I have the right to cry out that I am hurt, I'm in pain? But it seems that we are being silent, even at that level, that we cannot even cry out of pain. So, my sisters here, what do you think we should be doing? How do we address this? Because we can continue to talk from now to many years to come if we are not doing anything practical that we can do, that we can address the issue. It will continue to exist. We can't just continue to be silent, not to talk. But the question that I have, that I always ask myself, are we being affected by the myths that we believe? That if we talk or if we do something, that we are going to suffer the consequence. Maybe it's a myth. But I'm still looking forward to the time that people will come forward and challenge the situation with courage, not minding the consequence. So,
Yeah, thank
yes,
Thank you,
please
BC.
advise me. What can I do? My own corner there. What can I do? Because each time I think about it, it bothers me. We can't just continue.
Yeah. Thank you, BC. Dami, do you want to go first? I wanted to respond quickly.
yes.
So you can go first.
Yeah, and so you can respond quickly, and we'll
Okay.
kind of wrap it up, and take the
Okay.
conversation further in the future.
Once again, I want to just thank the leadership of PCANAT for initiating this difficult conversation, because we didn't even get to internalize racism and what it's done to all of us. I deliberately didn't go there at all. That's a different program entirely, what we need to do to get ourselves ready for these conversations. But BC, I think one way we can start even today is to take a program like what I call the critical health and racial literacy. It literally walks you through, even as a racialized person, how you engage in this conversation, how you negotiate this interaction across racial boundaries or issues around race. So I think actually we should think about even a partnership with PCANAT to do this. Right now, I actually just missed a meeting with a major hospital to look at how we can partner with them. I was supposed to be at that meeting at 1 o'clock. Yeah, but somebody to represent partner to offer this program to their providers. Maybe we should partner too to make sure that we actually have a shared understanding on how to negotiate these spaces, to have difficult conversation, bold conversation about racism.
Thank you. If there's
I'll
any
stop
way
there.
you can connect me in that program, I'll be glad to be a part of it.
I'll send the link. It's quite easy to scan and complete and register for the modules. It's a 5-module program. And we offer it every Tuesday on a webinar, or you can take it online on your own time. So it's synchronous as well. So I'll send it to Dami. Yeah.
Yeah.
Okay.
Yeah.
Please send it to my email, the one that I used to register for this event.
Yes, we'll do that, and we'll send it to all the attendees as well. And I just first want to apologize that we went way over time. These conversations, it takes longer to really unpack. And I'm really glad that we had this opportunity to discuss this during the Nurses Week. And we were strategic in choosing the theme of envisioning the way forward. And I know that we, at the individual level, we experience it, we know what it feels like. But if the systems, if the structures in place are not attuned to confronting racism, we'll continue to have these conversations over and over. And we've had some great examples from the UK, how they did it at the national level and how they operationalized it at the organizational level. And today is just a conversation starter. So I do hope that we'll keep continue to have this conversation and hopefully write some recommendations out of this conversation to the CNO, to our leaders. And Dr. Dodino, she's working on a research with CNA. So we have so many opportunities to put all of this together to shape Canada's future in the next few years and 10 years and 20 and 30 years. And we cannot do all of that unless we are all accountable. So I know in the room, we still have some white allies here. We have folks in leadership. We have folks in academia, we have folks in clinical leadership, we have students, we have professors, we have folks in clinical practice. We all have a role to play, right? So we cannot, confronting racism is not an individual role, it's a collective role. And Angela from the UK, Miss Jackson, Knight Jackson, and Jifa, you kind of enter my head. Now I can say it right. She's given us that call to action. What if? If she was not sponsored, she probably wouldn't be at the level where she is right now. So let's go with the what if. Let's ponder on that. And at the next time when we have another event, we'll start from where we stopped. And just before we go, I just want to thank everybody. I know 2 hours is not enough. P. Kennard, appreciate you for joining us. And at the beginning, we didn't talk more about what the organization is, and that was strategic because we wanted to dive right into it. But if you want to know more about the organization, we are a collective of different organizations across Canada. So PCANAD is a little bit different. It's not an individual member organization. It's a provincial/jurisdictional member organization. So, for example, if you're a member of Ontario Black Nurses Network, you are automatically a member of PCANAD. If you're a member of the Coalition of African, Caribbean, and Black Nurses in BC, you are a member. And if you're in your province, you don't have an organization, we do welcome you to be a provincial member. So if you've never connected with us, you're welcome to join us and we can all do this together. And of course, we welcome our white allies, we welcome other people of Africa of color, racialized individuals. We can all do this together. So thank you so much, everyone. And thank you, Dr. Etowa. Thank you, Dr. Chapman. I know she's gone. And thank you, Miss Knight Jackson. It was wonderful to have these powerful women in the room, and we look forward to a future conversation and, really talking more about this. And I wish everybody a wonderful Nurses Week. Do not forget to take care of yourself. You matter. You're doing a lot as a nurse, and you need to take that break to take care of yourself. Thank you, everyone, for joining, and have a wonderful celebration.
Bye.
Bye.
Thank you. Bye-bye.